The next speaker will be Dr. David M. Spiegel. He's a professor of medicine at the University of Colorado, and Dr. Bashinsky's already shown you a preliminary example of some of his work, and he'll be speaking with us about the therapeutic implications of altered calcium and phosphorus balance in the management of CKD, metabolic bone disease. Dr. Spiegel.
Thank you, Dr. Emmett. It's a pleasure to be here and a pleasure to be able to share the podium with my colleagues. Dr. Gutierrez has told us the wonderful mechanisms that come into play to help us maintain normal serum phosphorus as CKD progresses. And as Dr. Moe showed us yesterday, even to actually maintain normal phosphorus balance as CKD progresses until relatively late. And then Dr. Bashinsky showed us that how when we add a little bit of extra calcium to patients with CKD or patients on dialysis, we throw them into positive calcium balance. So while those two individuals showed you great science, I'm going to wax philosophical with you a little bit today. And the topic I was given was the therapeutic implications of altered calcium and phosphorus balance. And I'll approach that in a number of different ways. So what I'm going to suggest to you is when we think about why do we have these elegant mechanisms to maintain phosphorus balance, but we can't do a good job of maintaining calcium balance when we add calcium, which normal individuals can handle, why patients with CKD can't handle that. And I'm going to suggest to you that there are really no evolutionary adaptive pressures for chronic kidney disease, for survival in chronic kidney disease. And that is because fertility goes way down in patients with chronic kidney disease. And also most chronic kidney disease appears after reproductive years. So in the true evolutionary sense, we don't adapt to chronic kidney disease. And I'll suggest to you that the adaptation, what we call the adaptation that we see in chronic kidney disease, is really the evolutionary pressures for acute environmental stresses. And when we think about what the environmental stresses are, for phosphorus, I think that stress is to handle acute phosphorus loads. And for calcium, evolutionarily, that stress has been to move from a very high calcium environment, mainly seawater, to a relatively poor calcium environment, meaning land dwelling. And for those of you that are visual learners, and those of you that may still be hungry, this is, I think, a visual explanation for what an acute phosphorus load may be. And this is the evolutionary pressure that we face when we move from seawater, which is very high in calcium, to freshwater, which is lower, and now to land, which is very, obviously poor in calcium other than what we take in. And this is why we have elegant mechanisms for absorbing calcium from the gut, and calcium balance is maintained by urinary calcium excretion. So I broke this title down into two aspects because I think there are implications from disordered calcium and phosphorus balance, and then there are also potential complications or effects of the therapies that we use to try to manage calcium and phosphorus balance, and I want to look at those two separately. So this is a complex slide, but what I want you to look at, and our previous speakers have kind of talked about these numbers already, is that we absorb a lot of phosphorus from our diet, depending on the source, anywhere maybe from 50% all the way up to 90% of some of the inorganic phosphorus. So we absorb a lot of phosphorus, but as you can see, the phosphorus we absorb in CKD, we're able to excrete in the urine by those mechanisms that Dr. Gutierrez showed us. Calcium is also absorbed, as Dr. Bashinsky pointed out, but urinary calcium excretion is quite low in CKD, and there are a number of studies to show that, and it really doesn't increase when we increase calcium absorption. So we maintain calcium balance because we absorb about 200 milligrams on a 1,000 milligram intake. We excrete some of the urine and some is lost in the sweat. And as you know, these mechanisms, these hormones change in the background. PTH goes up, FGF goes up. I probably should have said that in the opposite order. FGF goes up, PTH goes up, and 125D goes down. And those are presumably the adaptive mechanisms that help us maintain phosphorus balance as we progress through CKD. And as you know, and as Dr. Bashinsky has alluded to, these disorders then of calcium and phosphorus balance, excess calcium, excess phosphorus can't stay in the extracellular fluid, and it presumably moves to soft tissue. We would like it to move to bone, but the evidence is very slim that it moves to bone. So what then are the implications of altered phosphorus balance? As I said, we are elegantly adapted to handle acute phosphorus loads, but chronic kidney disease is really a very abnormal state. It's really a chronic stimulation of those acute adaptive mechanisms, and it's characterized by those hormonal changes that I showed you. And so I think the implications are, one, the implications of the phosphorus load itself. And as you know, there's excellent data from Dr. Giacelli showing that cells, vascular smooth muscle cells exposed to high phosphorus levels undergo a phenotypic transformation and behave like bone-forming cells. So we think that phosphorus load in and of itself has deleterious effects. And now what's becoming very clear is that the hormonal changes that occur in the background now, and FGF23 is very exciting, that these hormonal changes and the increase in FGF23 that occurs may have deleterious effects in and of itself. And this is just one slide from a paper published late last year in JCI showing that in this animal model, increased levels of FGF result in LVH, and it appears to be sort of a off-target effect, if you will, of FGF23 due to the high levels and presumably not dependent upon the Klotho cofactor, which is normally important in the physiologic role of FGF23. So phosphorus itself is probably deleterious, and the chronic stimulation of these acute adaptive mechanisms appear also to be deleterious. And there was just a poster yesterday that even in children you can show that there's a correlation between serum FGF levels and LVH in children with chronic kidney disease. So that's a very exciting area of investigation. Well, what about the implications of altered calcium balance? Again, we are elegantly adapted to live in a calcium-poor environment. And acute loads, as we said, are handled through increased urinary excretion. But as we mentioned before, and as Dr. Bashinsky told us, CKD is characterized by very low urinary calcium excretions. And the implications of this are that when we take in excess calcium, it leads to positive calcium balance. And that is particularly true when we supplement patients with 125D or the analogs, as Dr. Bashinsky has also showed us. And this is just one slide showing the implications of this. This is a slide from some research of Catherine Shanahan. It's also from children, and the nice thing about looking at the vessels of children is they're not tampered with by all the things that adults do and adults do to their vessels, such as smoking and hypertension. So children's vessels are relatively pure in that sense, and so studying children is a unique opportunity to look at the effects of chronic kidney disease without a lot of the other effects that adults do that we know affect their blood vessels. And what she showed was on the left-hand side here is that children without kidney disease have very low levels of calcium in their vasculature. This pre-dialysis blood vessel is children who were having PD catheters inserted as they were beginning to be started on dialysis. And so even before they start dialysis, a lot of these children were already receiving calcium binders or calcium supplements. They already had increased vascular loading of calcium. And once these children started on dialysis, that was the third set of dots, they have a marked increase in calcium in their blood vessels, even before you can see that radiographically by X-ray or CT scanning. So we have data that calcium is accumulating in the blood vessels of children on slightly supplemented calcium diets. So what are the consequences of all this? And I think this is terribly important. What I show here is on the upper left a blood vessel with significant atherosclerotic disease, and our patients are certainly get coronary artery disease. And then next to that you see a large blood vessel with medial calcification, and as Dr. Bashinsky pointed out, this is very, very common in patients with chronic kidney disease. And the lower picture is a kind of a typical heart of someone who's on dialysis. It has marked LVH. And I think the combination of some intimal disease, that causes restricted blood flow, stiff vasculature, which changes blood flow rheology, and LVH, which puts the endocardium at risk for ischemia, results in endocardial ischemia and sudden death, which is the most common cause of death, the cardiovascular death, in our dialysis patients. Now, the cause for each of these is complex and multifactorial, and certainly the intimal disease is due to lipids, oxidized LDL, probably inflammation and other factors. The LVH is certainly due to pressure overload and volume overload and myocardial stunning and probably microcalcifications and now maybe FGF. And I think how complex each of these are points to the fact that a lot of the studies that have tried to target one of these mechanisms maybe hasn't shown a significant benefit. And I think the medial calcification we see is a direct result of what we call disordered mineral metabolism in our dialysis patients. And I think this is one of the major causes for cardiovascular death that we see. So what are the implications of these disorders? What's the implication? This is supposedly a hydroxyapatite crystal. What are the implications of elevated phosphorus and elevated phosphorus loads? Now, this was an elegant study done a long time ago, back in 1972. Think about what you were doing in 1972, some of you who were alive then, I guess. And this was a study done by Dr. Slatopolsky, and what he did was he took dogs and he did a progressive reduction in renal mass, and he followed that with a similar reduction in phosphorus intake, as you see. And what he found was when he lowered the phosphorus intake in these dogs as he lowered the renal mass, it was a relatively short study, you can see, but the serum phosphorus stayed normal, the serum calcium stayed normal, and the PTH also stayed normal, as did the tubular reabsorption of phosphorus stayed normal, high, which is also normal. And in the control dogs, if he just did the renal ablation without lowering the dietary phosphorus, the PTHs went over 1,000. Okay, so in this very short model, by lowering dietary phosphorus, he was able to at least prevent the rise in PTH. Now, they didn't know about FGF23 back then. It would have been very interesting to have that data. They didn't have frozen samples for that long, I don't believe. In a longer study that Dr. Slatopolsky was also part of, it was a similar type of study, a dog model of chronic kidney disease with renal ablation. And the CKD bars were the renal ablation without a reduction to dietary phosphorus. And the other lines that say CKD phosphorus reduction was the renal ablation with the corresponding decrease in dietary phosphorus intake. And this study was now over a 2-year period of time. And what you can see is that the dietary phosphorus reduction also tended to blunt the rise in PTH on the left-hand graph. And on the right-hand graph, you see that when they looked at bone biopsies in these dogs, that changes of renal osteodystrophy were very common in just the renal ablation model, but when they did the dietary reduction of phosphorus model, they were able to markedly blunt the renal osteodystrophy, the high turnover bone disease, in this dog model, corresponding with the blunting of the rise in PTH. So we don't have that kind of data on good dietary phosphorus reduction in humans, but we do have this recent study that was published earlier this year by Dr. Block with a large group of advisory panels, although he did certainly most of the work. And it was looking at the effects of phosphate binders. Now, I tried to make a good distinction between dietary phosphorus reduction and phosphate binders because they're not identical. They're different mechanisms to try to get at the same problem. The goal of therapy in this trial in CKD patients was to reduce the phosphorus to less than 3.5. And what I listed here is the doses of the binders. There was a progressive escalation of binders to try to achieve that goal up to a maximum. And you can see these patients were on relatively large doses of binders to try to get their phosphorus of less than 3.5. And these were CKD patients. You can see they were taking in, on average, about 1.5 grams of elemental phosphorus, already a little bit higher than the Institute of Medicine recommends. And this is the results. So the graphs are in the supplement to the article, which show the individual binders broken out. The data underneath the graphs is the way the statistics were pre-planned for the study, which was to compare all binders to the control group. So the phosphorus went down. It went down from about 4.2 in the control arm to about 3.9 in the binder arm, which was clinically significant. And you can see in the graph that all the binders tended to lower the serum phosphorus. On the right-hand side, you can also see that all the binders also tended to decrease the urinary phosphorus, meaning presumably they were decreasing gut phosphorus absorption, and they all were relatively equal there. And the binders were significantly better than the control group. When it comes to the PTH, it's interesting that the control group, the black dots, had an increase in PTH over the course of the study, which was about 9 months. And when you looked at all binder therapy versus the control group, there was a statistical difference such that the control group had an increase in PTH, where the binder group, the PTH was relatively same. And you can see on the individual binders, there was a little bit of difference, but overall a lot of overlap. The subgroups were small and not much difference. When you looked at FGF23 level, overall there was no difference in the control group versus all binder group. This looks at individual phosphate binders, and you can see that there may be some differences in phosphate binders in terms of the effects on FGF23, and it was also in this paper differences in terms of which assay you use for FGF23. When they looked at bone mineral density, there was also a difference, and that is bone mineral density increased in the binder group compared to the control group. Okay, so that was statistically different when you compared all binders versus the control group. When you look at the individual binders, again, you see some differences. The bone mineral density may have increased a little bit in the group getting calcium and not too much in the other binder group. Okay? On the right-hand slide, though, you see the changes in coronary artery calcification. Again, the primary statistics are when you compared all all binder group versus all placebo group, the all binder group had an increased progression of the coronary artery calcification relative to the control group. When you looked at the individual binders, you can see that that was predominantly driven by the group getting calcium-based binders, but the other binders had some differences also. Okay? And that was the principal findings of this article. So what are the effects then of, I showed you in animal models, the effects of dietary phosphorus restriction look very good. When we look at the effects of phosphate binders, we see that phosphate binders do decrease the serum phosphorus, at least somewhat in CKD. They do decrease urinary phosphorus excretion, presumably decreasing gut phosphorus absorption. But different binders may have differing effects on FGF23, maybe on bone structure, and maybe on vascular calcification. So what are the implications of calcium? And then I'm going to show you 3 studies that I think you've all seen. They're all, or some of them are small, they all have problems, but I think when you put them all together, they begin to tell us a story. This is a study out of Italy. This is in patients with chronic kidney disease who are randomized to calcium-based binder or sevelamer non-calcium-based binder, and they followed them over time in terms of mortality. And what they found was that the group getting the non-calcium-based binder had better survival than the group getting calcium-based binders. This was not an intent to treat, but this was in a patients who stayed on treatment analysis. Okay? And this was published earlier this year. This is older data which has been previously published, and I know you all have seen. This is, again, the study by Dr. Block called R&D trial. Patients were randomized to sevelamer versus a calcium-based binder for 18 months and then followed out over 5 years. And again, it looks very similar to the other study, and this was now in patients starting dialysis, so incident dialysis patients. The previous study was CKD patients. And this study also found a survival benefit to the non-calcium-based binder. Again, small numbers. This had about 120. The other had about 180 patients. This was the big trial to kind of answer this question, sevelamer versus calcium-based binders in now prevalent dialysis patients, so patients who had been on dialysis for 2 to 4 years. And what you can see was that in the overall analysis, there was no statistical difference in outcome in terms of survival. The study was problematic in the sense that there was a lot of dropout early in the study, especially in the calcium-based group, and some of the subgroup analyses were different. But again, sort of an inconclusive study. So we have 2 small positive studies on outcome, the large study, sort of an inconclusive study, if you will. And so the question I think still remains is, do calcium-based binders versus non-calcium-based binders affect mortality or hard cardiovascular outcomes? And I think that's why we have this discussion. That's why there's so many people in the room. Is it still a debated topic, and we don't have any definitive trials in that area. So what is the bottom line on calcium then? The Institute of Medicine has lowered their recommendations for the general population. Those of you who heard Graham Elder's talk yesterday, he gave a very nice talk on the controversies around calcium in the general population. And the chart on the bottom is those recommendations. The average requirement for men is now listed as 800 and 1,000 for women, at least when you get over 50 years old. The recommended daily allowance is 1,000 for men and 1,200 for women. And the recommended daily allowance, what the Institute of Medicine means by that, is that's the amount of calcium that satisfies the nutritional needs for 97.5% of the population. And the upper limit of safety has been lowered from 2,500 down to 2,000. So my take on what's reasonable in patients with CKD is there's absolutely no rational justification for administering greater amounts of calcium to individuals with minimal urinary excretion, namely patients with CKD and ESRD, than one would recommend for the general population. And Dr. Bushinsky has shown you the balance data and the modeling data, which suggests that around 800 to 1,200 might be very reasonable intake for our patients. So I think the title of this talk is absolutely right. It is all about balance. I think we need to try to achieve phosphorus balance early in CKD. That's both to avoid the deleterious effects of phosphorus and phosphorus loading itself, but I think we also need to begin to think about that part of the reason we need to control phosphorus balance is to prevent these adaptive mechanisms which are designed for handling acute loads but not the chronic load, and those adaptive mechanisms, I think, ultimately become maladaptive, and we need to begin to think about that. I think the recent study by Dr. Block suggests that we need to do this cautiously. Okay, we don't have definitive outcome data in CKD about different binders, about which binder is best, and so binders may not be the same as modulating dietary intake, and we need to keep that in mind. I think we need to try to achieve calcium balance throughout all stages of chronic kidney disease. We probably need to think about providing adequate calcium to our patients. Some of our patients, if we counsel them on dietary calcium restriction and dairy product restriction, may not take in enough calcium to maintain healthy bones, but on the other hand, we can't give them excessive calcium. And you know that one of the hallmarks of chronic kidney disease is the kidney loses the flexibility that it normally has, be it to handle salt, be it to handle water, and I think we see the same thing when it comes to handling calcium. And I think the dialysis procedure itself should be as close to calcium neutral as we can make it to avoid stimulating parathyroid hormone if we remove calcium, and also to prevent calcium loading during the procedure itself. And I will stop there and thank you for your time and attention.